But thanks everyone for dialing in, and for those that are interested in the work that's going on at the Productivity Commission. My name's Selwyn Button. I'm one of the commissioners that's on this particular review, and with me is Angela Jackson, who's my fellow commissioner that's working on this inquiry. So what we're going to talk through today is essentially the work that we've started around the interim report and some findings based on the interim report of the review of the National Mental Health and Suicide Prevention Agreement. And certainly what we want to be able to do is to talk you through the process to date, what we've found, what we've heard, and certainly next steps. So if we'll get stuck into it. And what we will do is to start by acknowledging country, and acknowledge the fact that I'm on the lands of the Yagara and Turrbal people in Brisbane, in the Anjan today, and want to acknowledge their ancestry and custodianship of this country, and acknowledging country where everyone else is located, including where Angela is today, I'm assuming, in the lands of the Wurundjeri people. Where we want to go is really starting to give a bit of an understanding of the things that we're seeing, and what we do know in terms of the landscape across the country. Mental illness continues to affect many people, and the prevalence rates of mental illness certainly is not decreasing. What we are seeing is that the overall prevalence across the period between 2007 and 20 to 22, we have seen significant increases in a range of issues. And certainly when we then start to look at specific populations, different populations are experiencing mental illness at a greater rate. And that is certainly one of the main reasons why we're wanting to focus on what's happening through the Mental Health and Suicide Prevention Agreement, because of those increasing issues that are occurring and increasing experiences that people are having with mental illnesses. Suicide rates remain unchanged over the 10-year period, certainly for the broader population, as you can see in the graph on the left. But looking at then standardised rates of suicide for Aboriginal and Torres Strait Islander population, certainly across the last 5 years, we have seen an increase in that for Aboriginal and Torres Strait Islander people. So we do need to pay particular attention to what's going on for the Aboriginal and Torres Strait Islander population, and we'll talk more about those sorts of things. But across the board, suicide remains unchanged, with the exception of the priority population of Aboriginal and Torres Strait Islander people. So the agreement itself, what does it entail? What's involved in it? It's an ambitious 4-year agreement. It was signed in 2022 between the federal government as well as all state and territory governments. There was a specific set of initiatives that are attached to it. So there's an agreement itself, which is a set of lofty objectives. Each state and territory then signed up to specific bilateral schedules that focus on the implementation of local initiatives that are specific to their needs. The reported progress against the current agreement that was signed, most of those were to be reported on an annual basis. There has been only one national report card in that period of time. There's a range of funding commitments that are attached to the agreement itself that total about $360 million, or it's only 3% of the $12 billion but it only represents 3% of the $12 billion that's spent on mental health and suicide prevention nationally. Governments have agreed to an ambitious set of targets without some obvious linkages between them. So within the agreement itself, it does contain 5 objectives. There's 5 outcomes that are involved. 15 priority populations are listed, 14 policy principles, and a range of actions that are attached to that. But certainly what we've seen in undertaking the assessment of the agreement is that direct alignment and linkage between all of those things is lacking. So it is something that we are calling out in this process we do need to pay attention to in a future agreement. It aims to achieve the significant outcomes that it sets out to undertake, because it does call out in terms of the objectives in the agreement. It's about improving the mental health and wellbeing of the Australian population and focus on improving outcomes for the priority populations, including Aboriginal and Torres Strait Islander people. It's about reducing suicide and suicidal distress and self-harm through whole-of-government approaches, which is about coordinating prevention, early intervention, treatment, aftercare and postvention. It's about providing a balanced and integrated mental health suicide prevention system for all communities. It's about improving physical health and life expectancy for people with mental health conditions and those experiencing suicidal distress. And it's actually about the quality, safety and capacity of the mental health suicide prevention system. So those are some fairly lofty objectives that sit inside the agreement. And as we've said, what we're looking at is how do you make sure that those things in terms of the outcomes and the outputs that are generated around them actually can track back to what's in those lofty objectives that are set out in the agreement itself. So what we were asked to do in January of this year, the Australian government signed off on the final review of the agreement, and the terms of reference that were provided to the Productivity Commission to undertake the work is to consider the wellbeing and productivity impacts of the mental health suicide prevention programs under the agreement, assess the effectiveness of the administration of the agreement, including the reporting and governance, and ensure the voices of Aboriginal Islander people and those with lived and living experience of mental ill health and suicide are being heard in the process as well. So where we're at in our inquiry process to this point, we have not that long ago, on the 24th of June, released our interim report. And certainly what we've undertaken so far is, post the inquiry being announced, there was a call for submissions. We did receive a range of submissions in that process. We did undertake a range of site visits and consultations across the country. And now we're at a point where we're calling for final submissions in relation to what's been called out in the interim report, with a view that as we progress across the rest of the year, in August, we undertake some public hearings with a view that we're moving towards handing our final report back to government on the 17th of October. So what's happened to date in terms of engagement and consultation? We've had 293 participants in our online survey. We've had 5 days of in-person meetings, as I mentioned, and in locations that we've been to have been Canberra, Brisbane, Hobart and Launceston. We've received 94 submissions through our online process. We had 54 online meetings, and we also then ran a webinar for a range of stakeholders interested to give a bit of an update on the work that we'd seen to date. What we've heard in that process, there's been some progress made, but it's not supported the meaningful improvements for people with living experience. So the significant opportunities that have been called out that we see to improve the next agreement is about centering the voices of people with lived and living experience and their supporters, families, carers and kin, strengthening accountability and governance, ensuring commitments are clearly linked to the objectives. Some of those, as I mentioned, some of those lofty objectives, there aren't the clearly defined outputs and outcomes that are attached to them. Some of the gaps that the next agreement should aim to address is about having this overarching national strategy, because it is being called out that there is no, or the last time that a national strategy was undertaken and developed for particularly for mental health was in 2008. We need to address some of the workforce challenges that exist, focus on prevention and mental health challenges and suicidal distress, more consistent planning, data collection and evaluation. There's been some progress in that space, but certainly it's calling out that we do need to pay more attention to it. So the interim findings, as we're presented to them, we're presenting back today, as well as it were provided to government, is that there has been progress made in delivering some of the agreement's commitments, but there's been little undertaken to create the systemic change that's required. The agreement has not led to progress in system reform. The agreement is not effective in looking at shifting the entire mental health and suicide prevention system, and there's been limited improvements in Aboriginal Islander social and emotional wellbeing over the course of the agreement. It hasn't supported positive policy developments in suicide prevention, but outcomes remain unchanged. What we're saying is that a new agreement is needed and can be more effective through better goal setting and linkage between commitments and goals. So what has it actually achieved to this point? So the actual assessment of the overall outcomes that have come out of the agreement itself, I guess what we're saying is a bit of a complex task. There are some challenges in assessing progress, particularly when you think about those lofty objectives that we talked about earlier, and then what's actually attached to the implementation plans or the bilateral agreements that are being signed between the federal government and states and territories, because there is not the correlation between the two. What we do know and what we can see is that there's limited public available information. So when you're thinking about outcomes that are attached to things like reforming the system, we don't actually have a hard and fast measure to show what does reform look like, and how can we measure whether or not reform is being implemented across the system. It's only been in operation for 3 years, so we should expect to see some things that actually haven't been undertaken yet, because there's still some issues around the implementation period that we're assessing at the moment. There's been some significant external factors, a range of things that have gone on, including, I guess, the ongoing nature of COVID-19 and the impacts that's had on the system. There's some key data gaps that remain, as I mentioned. The data story is starting to come together, but it's not complete. So there still is some data gaps that do remain in the system, and there have been delays in the monitoring and reporting process that's attached to the agreement, and delays in the information being provided and reports that are going from states and territories back to the Commonwealth to then look at undertaking an assessment of progress against all states and territories in a much more informed manner, in a timely manner, that then provides updated information to the public. So most national outputs have been delivered as part of the agreement. The analysis of psychosocial support services outside the NDS has been undertaken. The Commonwealth State implementation plans and the annual jurisdiction progress reports have been delivered. The National Progress Report has been delivered, even though there's only been one. The evaluation framework, the Suicide Prevention Office has been established. The National Guidelines on Regional Commissioning there's been some delays, whilst there's been a one-page that's provided guidance to the primary health networks across the country. What we've heard is that there's not sufficient information in that. The National Mental Health Workforce Strategy has been developed. There's been progress reports in relation to mental health professionals and workforce needs, and the submission to the midterm review of the National Health Reform Agreement has been undertaken. And as we mentioned, the final review of the agreement is currently underway, and that's what we're doing now. The other key achievements, as I mentioned, the National Suicide Prevention Office has been established, and they've also undertaken the process of developing the National Suicide Prevention Strategy. So there is the long-term whole-of-government strategy, and it has been well received by the sector, including people with lived and living experience who've been very much involved in the co-design of the national strategy. There's been progress, as I mentioned, in data sharing and linkage, but certainly we do need to see some greater sharing of data between jurisdictions, and there are some things that are going on in terms of some pilot data linkage projects being led by the working group, and certainly with the assistance of AIHW. There's been the development of the National Mental Health Workforce Strategy to include some detailed actions and implementation plans, and there's been the establishment of the 38 Medicare mental health centres as of June 25, and it is helping to certainly meet a gap and divert people away from emergency departments, but there are still more to be implemented. So we want to see those things expedited in the system, and certainly that's what we heard in conversations across the country as well. Some of the things that haven't been fulfilled, the focus on psychosocial support outside the NDIS, and certainly the gap in support for around 500,000 people across the country who aren't eligible for the NDIS, who do require psychosocial support, and were receiving some type of support in the past. Due to the introduction of the NDIS and the changes, I guess, in the funding nature and the resourcing of the NDIS process, some of those people are now missing out. As I mentioned, the National Guidelines on Regional Commissioning and Planning, there's been some progress on that. There's been a one-pager that's been developed, but certainly what we've heard is that, and what we're hearing is that there does need to be more detail that's provided to PHNs and to LHDs or HHSs across the country to support regional commissioning and planning. There's been the development of the National Stigma and Discrimination Reduction Strategy, which is still in draft, and certainly that draft was provided to government in June 23 after a lengthy consultation process, but it hasn't been released. And we heard a lot from people across the sector that said the issues around stigma and discrimination still exist, and certainly having the strategy released is something that they would want to see expedited and happen very quickly. And some workforce issues. There's actions that have failed to implement the impact of the chronic workforce shortages, and there's many actions that are in the National Mental Health Workforce Strategy that are yet to be delivered, and others that are taking time to filter through to the current workforce. So overall, essentially what we're saying is that the agreement as it currently stands is not fit for purpose. There's been progress made in delivering the agreement's commitments, but it's not led to the system reform that the objectives in the agreement are were designed and set out to achieve. The majority of the commitments in the agreement are not funded, which impedes progress. A good example of that is what goes on in the National Mental Health Workforce Strategy. There is a strategy, but there aren't funds attached to it. Roles and responsibilities aren't clearly defined, and certainly whilst we have a range of accountability mechanisms, what the alignment between the two or the coordination between those mechanisms that are informing the overall implementation of the agreement are not clearly defined. The agreement doesn't include meaningful action to advance the close the gap targets, and certainly there's been some work undertaken to then try and look at the alignment between the social and emotional wellbeing policy partnership as part of the close the gap process. It isn't still clearly defined in terms of what are the meaningful actions that need to take place to better support those implementing the close the gap targets itself. And there are no specific actions to support the priority populations. The agreement has supported some positive policy developments in suicide prevention, but outcomes remain unchanged. There are substantial barriers to the agreement's effectiveness. As I mentioned, the agreement's not been set up for success. We've got these ambitious objectives in them, but they lack clear alignment to how they're going to be achieved and implemented through the bilateral arrangements. We're lacking elements needed for system reform. It's very much a top-down approach, not necessarily in ensuring that we do have the voices of people with lived experience to then inform what that might look like. We also have inadequate inclusion of people with lived and living experience in the governance arrangements. They weren't involved in the original design, and they're certainly not involved in an ongoing capacity to positively contribute to the governance and certainly the rollout and the implementation of initiatives as part of the agreement. And the government, as we mentioned, the governance is ineffective. There are issues with transparency, some issues with accountability. There's the whole of government focus that's called out in the agreement objectives is not there. So it is very much missing. So what we're saying is that there does need to be better alignment and clearer roles and responsibilities to ensure that the governance process is very much about supporting the implementation of the agreement. So where to next?
Indeed,
Angela.
Selwyn. Thank you very much, Selwyn. Thanks for running through some of the key findings of what we found about the current agreement. And I guess the question now for us in the interim report is, well, where to next, and how do we address some of those issues and build a better agreement for the future? So to start with, we're looking at some short-term priorities. So there's some things that the Productivity Commission has identified that need immediate action. They include really looking at and starting to address the gaps in psychosocial supports outside the NDIS. As someone mentioned, we've identified a gap of around 500,000 Australians who are currently not receiving the supports that they need, and we're calling on state and territory and Commonwealth government to start addressing some of those gaps. The release of a national stigma and discrimination reduction strategy, it's one of the outputs that hasn't been delivered under the agreement, and we think needs to be a priority, and we're calling that the final strategy is released by the end of the year. This is important because it can help reduce some of the stigma, obviously, around poor mental health and suicide prevention that can sometimes stop people getting the help and the support that they need. So really starting to address that and rolling out that national strategy. The national guidelines on regional commissioning and planning. Now, this is really around how different levels of government work around place, around local communities, and ensuring that those guidelines are developed and released so that we can start seeing some best practice out there so that the services are linked up and that those gaps don't necessarily materialise that then people experience on the ground. So there are immediate short-term priority actions that we want to see occur before the end of the current agreement. Then what are we thinking around what does the next agreement look like? What are the steps that need to happen to build the next mental health and suicide prevention agreement between the Commonwealth and the states that better addresses some of these system-wide issues. The first thing that we think needs to occur is that we need to have a national mental health strategy. As Selwyn mentioned, we haven't had one since 2008 in Australia. There are a number of smaller strategies or strategies with a more narrow focus that overlap within the mental health system, but we think that there would be real benefit from a national approach. To do that, we think the current agreement, while we think it has a number of flaws, should be extended by 12 months, and that will allow for proper co-design to be the real foundation of the next agreement. We want to see improved governance and accountability structures. One of the real issues we see with the current agreement is that lack of governance, and that the accountability structures simply aren't as strong as they could be. Within that, clarifying the responsibility for things like workforce initiatives, full psychosocial supports outside the NDIS, and carer supports. Without really having that clear responsibility, it's very hard to have that accountability that then flows from that. In addition, there needs to be some new schedules as well in the current agreement, specifically around Aboriginal and Torres Strait Islander services. As Selwyn highlighted in one of the first slides, we've seen a recent increase in rates of suicide amongst Aboriginal and Torres Strait Islander people, and clearly within the Closing the Gap agreement, it is a priority area for government, but at the moment we don't see the outputs or the outcomes through this agreement. We think a schedule within the agreement to really focus the agreement would be beneficial, and also on suicide prevention to really back in the good work that has gone on in terms of the National Suicide Prevention Strategy. To have a schedule within this larger agreement would make the agreement much stronger going forward. So in terms of what a strategy can achieve, there are a lot of strategies out there, and we're conscious that it's not just a strategy for a strategy's sake. It really is around recognising that to achieve the system that everybody agrees that we need to have, it's going to take a long time, and we're talking around a 30-year period to really transform the current mental health and suicide prevention system into one that does provide that person-centred care, and that it doesn't have the current gaps that we currently see in the system. So that longer term reform vision, that 20 to 30 year vision, linking it clearly with the objectives in the National Suicide and Prevention Strategy, align the collective efforts. The thing around mental health in particular and suicide prevention is that it does involve all levels of government, and also the private sector, the community sector, and as a result we really do need everybody working together, and there's also critical importance around having those with lived and living experience and their voices heard as well as part of the system. So the way we see it working is that you have this overarching 30-year strategy, and then within that you design and implement the next agreement. So you have shorter 5-year agreements that form part of and work you towards fulfilling that 30-year strategy. And that will mean that the next agreement has a focus, and it's clear about what it is trying to achieve and what outcomes it's actually setting out to do. So in terms of the extended time frame, there could be some criticism here, but haven't you just said that the current agreement isn't fit for purpose? Why do we want to extend it? The real reason is we want to make sure that the co-design process and we have a renewed strategy in place before we then embark on a new agreement. Rushing into a new agreement and not doing it in a coordinated way and in a considered way risks making the same mistakes that we've highlighted in the previous agreement. So what we're aiming to do is have a new agreement in place by June 2027 that will be informed by a new national mental health strategy. The co-design process is a very important part of the process. It does take time to do this well, but ensuring that people with lived and living experience of mental ill health and suicide, their supporters, carers, families and kins have their voices heard, and can contribute towards the strategy in a proper co-design process, not just in name, but in actual fact properly co-designed is really important to ensure that what we're actually aiming to achieve and the way in which we endeavour and embark on achieving it is actually going to make a real difference in people's lives. We need to involve service providers as well and government departments and agencies. The important thing to remember in this space as well is that it's not just health departments, it's not just mental health providers, that building a mental health system involves housing, it involves the Justice Department, it involves education. It really is a whole of government approach to mental health that we want to see into the future. One thing that we really note in the current agreement is that there wasn't a clear theory of change. And then what that means is that the commitments weren't necessarily linked to the objectives and outcomes. It wasn't clear how what people were committing to do under the agreement was actually going to achieve what the agreement said it was trying to achieve. To do that, you need to have very careful sequencing. You need to be very clear about what you're trying to achieve and how what you're doing is going to get you to that objective, and robust evidence to really link what you're doing to what the outcomes you're trying to achieve. The whole of government approach, as I've already touched on, is incredibly important in this space, which is why we're calling on PM&C, which is the Department of the Prime Minister and Cabinet, to lead the negotiations across government, across the federal government and also with the states and the territories. That will help retain that focus on integration, that whole of government approach to improving our mental health and suicide prevention systems. In terms of prioritising areas, they should be in the areas that the renewed strategy is highlighting in terms of where the priorities need to be. And again, really embedding that whole of government approach to the agreement, rather than including that in it as a schedule or as an appendix to the agreement. Governance is an incredibly important part of this process. Whenever you have an intergovernmental agreement, ensuring that people are indeed undertaking what they have said they're going to undertake is important, and having accountability is important in terms of achieving those outcomes. So we're calling on the role of the National Mental Health Commission to be formalised in terms of its responsibility for the ongoing monitoring, reporting and assessment of progress against the agreement. We want to see it empowered to report on the progress using the information from not just the states and the territories that's provided, but from a broader range of stakeholders. And that the National Suicide Prevention Office should also have that monitoring, reporting and assessment of progress of the suicide prevention schedule. These independent bodies are an incredibly important part of the process. They give the community confidence in terms of what they are saying and in terms of providing that external validation, if you like, that what people are saying they're doing under the agreement is actually occurring. Greater transparency in governance is also important. It's important that the framework emphasises transparency and collaboration, that we understand who is on different boards as under the agreement and their activities of certain working groups, and that we see that the agreement's administration function is actually adequately resourced to deliver what it's trying to achieve. This, in particular, the current agreement does set out, quite an ambitious involvement for people with lived and living experience, but it doesn't necessarily live up to that. So we want to see a renewed focus on that and learn from the mistakes potentially of the current agreement, to see the representation of those with lived and living experience at every level of the governance process, that people with lived and living experience are involved in the negotiation and the design. Governance roles also for carers and providers, and formal role for the two Australian government funded peak bodies for people with lived and living experience. There also needs to be adequate resources for those peak bodies. It's very important that to fulfil these governance roles does take time and it does take resources, and that those that are being asked to undertake that role are properly resourced to do it. There does need to also be a balanced representation within these governance forums. People with lived and living experience of mental ill health, but also those with lived and living experience of suicide, recognising that they are different parts of the system and they need to both be represented. Carers and families also play a critical part in the mental health system and in the service provision and need to be involved within the agreement and also called out in terms of ensuring that the agreement provides support. So we need to clarify the responsibility for those care and family supports within the agreement between the Commonwealth and the state and territory governments. State and territory governments tend to take responsibility for planning and funding carer and family support services. There needs to be a greater role for carers and families within the governance of the next agreement, including carer involvement in the design and implementation of the agreement and a formal role in the governance arrangements going forward. There are real opportunities that we can see and that have been highlighted to us to improve the involvement of carers and families within the next agreement. Services that the agreement funds, for example, could look for opportunities to improve the way in which they are working with carers and families and make sure that they are also addressing their needs. Workforce is also a really important part of building this a national system for the future. And as Selwyn pointed out, the National Mental Health and Workforce Strategy has been completed. Unfortunately, there's been no funding provided. So we really want to see going forward that there are clear commitments and timelines to support the priority actions under the strategy, and that there's a real delineation and responsibility and that there is funding of those workforce initiatives. Without building the workforce for the future, we're not going to be able to deliver the services or the system reform that we all want to see. Part of that is around developing a nationally consistent scope of practice for peer workers. Now, peer workers are becoming an increasingly important part of the mental health and suicide prevention systems. A scope of practice would provide much safer work practices for that peer workforce. It would contribute to better outcomes for people accessing that peer support, and improve public understanding of the profession going forward. As I mentioned, Aboriginal and Torres Strait Islander services schedule is something we think is a priority for the next agreement. It's needed to recognise the unique factors affecting the social and emotional well-being of Aboriginal and Torres Strait Islander people. Aboriginal and Torres Strait Islander people in Australia experience higher levels of poor mental health, and we need to ensure that the system, alongside the Closing the Gap agreement and with the Aboriginal-led health sector, is delivering better outcomes for Aboriginal and Torres Strait Islander people moving forward. There needs to be an alignment with the existing and relevant agreements and strategies. So, as I mentioned, the Closing the Gap and the Social and Emotional Wellbeing Policy Partnership, the National Aboriginal and Torres Strait Islander Suicide Prevention Strategy. Cultural safety needs to be centred and needs to be a priority. We need to see a greater investment in the workforce, the Aboriginal and Torres Strait Islander workforce, the ongoing support and of the community-controlled sector, ensuring that they have funding, stability and certainty, and really clarify the governance and accountability for that schedule going forward. Suicide prevention schedule. There are areas unique to suicide prevention that should be included in this separate schedule. There are obviously areas of overlap as well with the broader mental health, which should be in the body of the agreement. So if we think around the overlap, there is a whole of government approach needed to embed lived experience throughout the system. Whether that's mental health in terms of early childhood, mental health promotion, mental health literacy and resilience. In the suicide prevention, means restrictions, aftercare and post-intervention services. So in terms of what we'd like to see in the new suicide prevention schedule, alignment between the schedule, objectives and the longer-term national strategy that has been developed, co-design with people with lived and living experience of suicide and service providers, clarifying the roles and responsibilities for areas specific to suicide prevention. So funding arrangements and evaluation are always a pretty important part of any national agreement between the Commonwealth and the states and territories. National leadership is not around stopping the flexibility in the service delivery or the evaluation efforts that are occurring, and they should continue. What we want to see really at this national level is focus on areas where there can be efficiency gains. We want to ensure that the funding arrangements can provide sufficient flexibility to commission locally relevant services. This is very important that we see, you know, at the local, whether it's the primary healthcare network level, that people can identify, well, these are the needs of our community, and they have the flexibility to provide those services that their communities need. Evaluations conducted for all funded services to ensure that, you know, what is being delivered is working and is delivering on the outcomes that that's intended to do. And the sharing of those findings, those evaluation findings, including publicly where possible. This is about accountability, but it's also about ensuring that there are learnings across the system. So the next steps, we're currently receiving public submissions until the end of July, the 31st of July, and we really encourage people to put in a submission to tell us what they think about what our interim findings and our recommendations. We'll be then moving to provide to hold some public hearings in early August. With a mind towards finalising the report to be delivered to the Treasurer by the 17th of October this year. And that report will be tabled by the Treasurer within 25 sitting days of Parliament after he receives the report. In terms of contacting us, we really are looking to, you know, hear from the public, from those with lived and living experience about what they think of the mental health agreement and what their reaction to the interim report. You can contact us at mentalhealthreview@pc.gov.au, and we really welcome your feedback. Thank you for listening today.